So we need to just talk about the another topic, but that goes with lots of the SI issue and the fixation distal pelvis. Anyway, whether we should do anterior and posterior surgery for correction of adult deformity. Classically, we can rely on the Smith-Pearson osteotomy or pedicle subtraction osteotomy, VCR. And how about anterior surgery, whether we do it in the classic fashion or even mini open or what we call anterior ACR, anterior coronal reconstruction. So basically, when you have a patient, you have some choices where you have no other choice than posterior surgery. Which case are these? When you have a previous fusion that's a circumferential, the patient already had an AP fusion at the level of the desired corrections. You may have a patient that any anterior surgery is precluded because of multiple anterior previous surgery, previous access to it, morbidly obese patients. We have some specific disease that are not very good for anterior surgery, like ankylosing spondylitis. And you may have patient choice. You have some patient who it's out of the question that you're going to do any anterior surgery. So you have to decide to do posterior surgery. So this is the ankylosing spondylitis patients where to do anterior surgery for such case is not going to do the work. You're going to have osteoporosis in the front, it's fusing in the back. So these patients, you have no other choice but to do a pedicle subtraction osteotomies. And in this patient, we had to do 2 pedicle subtraction osteotomies from the back to get the alignment right. And the patient did well. Similar cases in this patient who had a previous fusion for kyphosis and developed a proximal junctional kyphosis at the upper end of the construct. She had a previous anterior surgery, as you can see it. So there's nothing you can do anteriorly to help you with the correction. So you have to do everything posteriorly. And this patient, we put her in a traction suspension and did a VCR at the apex of the curve to get the correction, because there was no possibility to do any anterior surgery. However, we should always remember that when we do all this surgery from the back, there's a high complication rate, and it's been reported to be more than 50%. The complication rate varies between 11-15% to more than 30%. You may have excessive blood loss. It's sometimes difficult to tune in the right low doses correction you want, and you have in the long term, a significant amount of pseudoarthrosis and loss of correction. So then obviously, after the posterior-only surgery, when you have no choice, you have the situation where you can do either anterior surgery or everything from the back, and that comes a little bit to a dealer choice. The anterior support, you can provide it with a T-lift or an A-lift if you want an O-lift. It may be also related to your training, to see if you're very comfortable doing everything from the back or you're very comfortable doing front and back surgery. And there's a question of your reliability of your access surgeons. And I have to say, I have some access surgeons I don't use anymore because I know it's going to have some issues. And obviously you have the patient choice. Once again, patient doesn't want to have any anterior surgery and is reluctant to have it, so you do everything from the back. So this is an adult scoliosis, a very painful. There's conservative treatment been tried for years and years, and then she decided to get the surgery. And in this patient, I like to get anterior column support at the bottom of the fusion at 4.5 and 5.1. You could do it either from the front or from the back. In this patient, I did a T-lift at the 4.5 and 5.1, and the patient did really well. But this is an anterior column support that could have been done from the front as well without any problem. Patient was thin, could very acceptable to do it from the front. So now you have some situation where the simple posterior surgery is not going to be enough, and your choice is either going to do a PSO, VCR, or anterior posterior surgery. I'd like you to go over some cases where we do definitely anterior surgery. So this is an airplane pilot retired who comes in with a significant amount of low back pain. He's went to see his previous surgeon. We told him there's no stenosis, mission accomplished, there's nothing I can do. Looking at the plain X-rays of the lumbar spine, is doesn't seem to be too bad. If you look at his EOS film, you're going to see that he has a severe sagittal decompensation. So to realign him with a TILIF would be quite challenging, because you're only going to get 15 degrees in the best case scenario if you do a TILIF at 5-1. Now, if you go anteriorly with the new hyperlordotic cages, you're going to get 20 or 30 degrees depending on what you want. And this is going to do the job relatively easy. So this is a patient, we went in anteriorly and with a hyperlordotic cages. He had the extremely strong bone, so we didn't think it was necessary to put any iliac bolts. And his back pain disappeared. You can see the difference in the sagittal alignment for this patient. So this patient definitely anterior surgery was a good way to do it, because TILIF would not have been able to give him this nice sagittal alignments. Now you have the classic patient who had a previous Harrington Harry Lukey, like in this one, who comes in with a severe low back pain years afterwards. And you could argue, I can do a PSO to realign her. I've done many PSO on these cases, or you can do it at front and back. The problem with doing a PSO, you're going to have a high rate of rod fracture. You're going to have psoriasis or increased risk of neurologic risk, and you still have to do anterior column support below and your PSO. That's a lot of work. So this patient, you can see she has a very positive sagittal imbalance. She's retroverted pelvis. She's bending her knees, and we did anterior surgery 5-1. Hyperlordotic cages, took us an hour and a half to do it. And then posteriorly, the Smith-Peterson osteotomy controlled the L5 nerves and link it to the previous rod. And patient was out of the hospital within 3 days. So, which I think was less aggressive than the pedicle subtraction osteotomies. Other cases are more extreme, and this patient who had a previous spine fusion done to L5, and she can hardly stand up. She has difficulty breathing, as you can see, because of a sagittal deformity. She has lost difficulty horizontal gaze because of sagittal deformity as well. And we just do a little bit of workup on her. We see that she had extensive laminectomy from the whole lumbar spine. So to do a pedicle subtraction osteotomy in this case, you're going to have to deal with the scar tissue, and I do it, but only when there's no other choice. And then you see the patient to get a correction. It's more than the amount of hyperlordotic case you can do. So in this patient, we decided to go anteriorly to do to make a 40-degree hyperlordotic cages after a tall cage. So we trim it to get 40 degrees. Now you have some cages that come with a 40 degree, but at the time they didn't exist. So we made a 40-degree hyperlordotic cages, inserted it, checked it. We were not happy with the position of the cage because you see there's a mismatch between the end plate of the cage and the S1. We therefore repositioned the cage to have a good mismatch. The correction didn't seem to be appropriate, but we knew that posteriorly we would do a Smith-Peterson osteotomy and get the rest of the correction. That's what we did. And you can see that after Smith-Peterson osteotomy and before the Smith-Peterson osteotomy, we've been able to achieve a significant amount of correction. And this patient, we only had to do anterior surgery 5-1 and then posterior surgery with a Smith-Peterson osteotomy, and we got the alignment right without having to do very extensive PSO. It would have required a 40-degree PSO and a TILIF at 5-1. So that would have been a lot of work. And this patient were able to do it without too much work. Now with anterior surgery, you can also do oblique lumbar interbody fusion, antipsoas with hyperlordotic cages. That's possible. This is another patient who is obese. She had a previous abdominal surgery, but she didn't have any lateral surgery. So we did some workup, and we thought that we could get the correction with a lateral, a no-leaf approach. In this case, if you want to get the correction, you need to do a resection. It's not to cutting the hairline. You have to resect it all the way around, from the left to right, if you want to get correction, if you don't want your cage to settle to plow into the bone. So you have to do AL resection and then you can put your hyperlordotic cages, and we did 2 levels in order to achieve the correction. And the patient was well balanced afterwards, as you can see on the EOS films. In some cases, you have to combine the anterior and the OLIF cases. This is another patient who had a previous lumbar fusion. She's in very severe kyphosis. She had also previous laminectomy, so going in the back to doing a PSO with all the scar tissue. For me, it's a bit a nightmare, and so I thought there was another way you could do it. You can see she has 2 free discus space, one at 5.1, the other one at 1.2. So we went first stage at 5.1 and put the hyperlordotic cage, as you can see on the left side of the screen. And then we went afterwards at the 1 and 2 with another hyperlordotic cages, and that was the stage 1. And then afterwards, 2 days later, we just put the rods in and got the correction we wanted. And that's a patient pre-op on the left-hand side and post-op on the right-hand side. You can see we could achieve the alignment. Then you have some cases as well. You can discuss whether you should do an asymmetric pedicular subtraction osteotomy or whether you do front and back. And that's, I agree, it's a little bit pushing the envelope. But this patient who had a previous fusion with a severe trunk obliquity, as you can see, and Jean would call it pelvic obliquity. I like to call it trunk obliquity, and sagittal imbalance. And it has lots of pain, but it has 2 free discus space at the bottom, if you look correctly. So what we did in this patient went anteriorly at 5.1 and 4.5, did the extensive release at the level 4.5 and 5.1, over distract 4.5 and 5.1, and put a smaller cage in the front to be able to get correction posteriorly. When we went posteriorly, we did extensive Smith-Pete at 4.5 and 5.1, and we were able to correct the coronal plane. Not completely perfect, as you can see, but pretty well. And the patient's been very happy with this type of surgery. So instead of doing an asymmetric pedicular subtraction osteotomy in this case, it was still possible because we had 2 free discus space to get the coronal correction. Now, anterior surgery, that's a new concept that we developed. Can we overpower previous fusion? And this is a case you can see previous extensive instrumentation to the sacrum, previous TLIF at L5S1. So it looks like the patient had a 360 fusion at 5.1, but there's definitely pseudoarthrosis. So pseudoarthrosis is your friend. When you have a deformity to correct, if there's a pseudoarthrosis, that's your friend. You go after it and say, yes, I can just move everything at the level of the pseudoarthrosis. So we went anteriorly, and anteriorly, as there was this pseudoarthrosis in the back, we could move everything. We first remove the teeth cages at 5.1, and then put these hyperlordotic cages. And you can see on the left-hand side, that's our prior to go posteriorly. And then when we went posteriorly, put the rods in, did the Smith-Peterson osteotomy once again to control the L5 nerve. We could get a further correction and a very good correction to achieve a good sagittal alignment. As you can see on your slides, a good coronal balance as well. Same thing on this patient who had severe sagittal decompensation, circumferential fusion with the TLIF cages at 4.5 and 5.1. So we went first in the front to remove the cages. That before the cage had been removed. On the right-hand side, you can see the cage. We've removed the cage and put hyperlordotic cages in the front. And when we went back posteriorly and did the Smith-Peterson osteotomy and corrected it, without doing much in the back, more than the Smith-Peterson osteotomies. When we look at the literature result, there's a very interesting paper that was recently published in European Spine Journal by the European group, and I looked at the matched control study between anterior and posterior surgery, and the combined approach, anterior and posterior surgery, had obviously longer surgery time. They had more blood loss in their series, but that's not my experience. As a matter of fact, maybe technically I'm not very good to do PSO, but when I do front and back, I lose less than if I do a PSO. Longer ICU stay, yeah, that's it's true that sometimes the front and back stay longer in the ICU, and the same complication rate. But very interestingly, the front and back surgery had less readmission, 9% versus 38%, less reoperation, 18% versus 43%, and better outcome from the SRS. And we looked at our own series that was 6 years ago, initial experience of 41 patients who had adult degenerative spine disease or deformity, where we had put these hyperlordotic cages. We could see that basically we're achieving the same amount of correction that the lordotic cages were choosing, meaning that if we pick a 20-degree lordotic cages, we achieve 20 degrees of lordosis. If we pick 30 degree, we're going to achieve 30 degrees of lordosis, except in spondylolisthesis, which was not true. We had a good correction of the sagittal alignment. We had, unfortunately, a complication rate of 20% with a 5% transient neurologic complication, but which is less than the posterior basal osteotomy that we perform. So I think there's the wheel is coming back again. We used to do lots of anterior and posterior surgery 30 years ago. Then afterwards, when the PSO technique came along 20 years ago, everybody just jumped on the bandwagon of the PSO. And then now it's coming back to more anterior and posterior surgery. In our experience, we have less blood loss than the three column osteotomies. Our complication rate are less than the three classic osteotomies. And it looks like from the literature, the long-term outcome seems to be better. Thank you. I have got this slide, interesting as a matter of fact, slides of the patient before and after this type of osteotomy. Oh, it doesn't. So what you can get an old person from back to a young person by doing this very extensive surgery.
What a great visual, Vincent. Better than any outcome store. Congratulations. And you clearly are one of the great disciples of the French school of artistry, and combine that with mechanics of the spine. And it's just beautiful to see your spines, and beautiful to see this nice lady reclaim her life by having a well-balanced spine, all in the lineage of the great Professor Dubuisset. So thank you, Vincent. I have a critical question for you. So in orthopedics, you're an orthopedic surgeon. We have the concept in America of open reduction internal fixation. I personally may be biased, but I have seen far more OIF, open internal fixation cases, especially as surgeons become enamored with less invasive techniques where they can poke hardware into a patient through minimally invasive fixation techniques. Is this just a bad prejudice on my part, or is there some substance to this perhaps?
I think the type of cases we've seen, maybe in the future they're going to be minimal to minimal invasive surgery. In my hand, I don't know how I can do this with minimal invasive surgery. You have to correct. It's not only the placement of the screws the problem. It's a placement to achieve the correction. And I'm an old-fashioned trained surgeon, so I still do this patient in a conventional open fashion. Obviously, when I go anteriorly, I use minimal approaches, so it's not very, very extensive. It's not the big sharp bite we used to have in the patient. But most of these patients had the previous multiple surgeries, very often 5, 6, 7 previous surgery. I don't think they're that much amenable to minimally invasive spine surgery. But Dr. Pimenta was here. I'm sure is going to demonstrate his skill to achieve this kind of solution.
Great point. So again, if I understand what you're saying right, is anterior and posterior surgery may be necessary to correct these procedures, and the conventional posterior 3-column osteotomies, which rely largely on resecting a vertebra, are pretty bloody. How about using more of the disc space, like intradiscal osteotomies, to get rebalancing of the spinal column and maintaining neural column height?
Yeah, I think it's a very good point. I know the answer. You're a specialist of the transdiscal osteotomy with a TLIF, and it's and you have I know your cases, you showed great result. I sometimes do a transdiscal osteotomy with a TLIF. My thing is doing one TLIF, it's fine. Maybe do 2 TLIF, but when it comes to doing 3, for me, it's too overwhelming to do a multiple TLIF in the lumbar spine. So I can't, personally, I can't take it anymore. I can take 1 TLIF in a patient, I can do 2. If I have to do more than 2, I say I can't take it anymore. So.
We have the past president of the Scoliosis Research Society sitting there, Dr. Chris Shaffrey. Any comments on Dr. Arlet's discussions, anterior, posterior rebalancing the spine?
Well, I will tell you, as a former partner of Dr. Arlet's, he is a masterful technician. He does really, really nice stuff. And the only thing I worry about, Vincent, I'd like you to comment. I get a little concerned with these, 30, 40 degree cages because they're so big anteriorly, but they don't open the foramen much. And I've had 1 or 2 patients where I've done aggressive anterior opening and then posterior compression where they developed a radiculopathy or some weakness afterwards. And I was wondering if that was a consequence of not doing, opening by posterior distraction the foramen. So I'd love to have, because you've done this and you do such masterful work, I'd be interested to hear what your comments are on that.
Chris, I think that's a very, very good question because obviously you look at the pedicle retraction osteotomy rate of neurology complication and they are out there. So you wonder whether going anteriorly you're going to decrease your neurology complication, but they do exist as well. And in order to decrease the neurology, you have to put a tall cage in the back. Obviously, so you not to decrease the foraminal height, but even though it may not be enough, and I think the threshold to go posteriorly and to do a Smith-Peterson osteotomy and to control your L5 nerve root or L4 nerve root, which depends on the level, should be extremely low. Then there's a second issue, and I had 2 patients who developed a drop when I'm convinced that it didn't exist at the hospital. They developed it late, 2 weeks afterwards. And just when my partner, Dr. Oster, had the same experience doing this. So we've seen patients who were in the hospital had perfectly, after hyperorthotic cages, had perfect function of the L5 nerve root, then they come to the clinic with a drop for 2 weeks later. And this is really, really a little bit of concern, and we have no explanations, probably stretching of the nerve root. So it's, I don't know if any of you have seen this complication of late, just like a C5 palsy, just late, L5 radiculopathy after these hyperorthotic cages. So they don't offer a solution for the cases, just like it's not. But I think you have to weigh the pros and cons, go posteriorly, anteriorly, and but definitely they're very powerful and it can make sometimes your life much more simple.
Many more questions to discuss. We need to move to the lab, but I have one last question, so I'll take the prerogative of asking you that for now, but hopefully we'll have you on for critical commentary. So my question pertains to, again, the general gestalt of the spine, the big picture. You've reestablished beautiful alignments in these complex 3-dimensional deformities. As Professor Dubuisset pointed out, these are truly 3-dimensional, including the horizontal plane deformities. How do you intraoperatively ascertain that you have the cervical spine in alignment with the lumbopelvic axis again? Again, they're so beautifully reconstructed. Is this just your eye and your experience, the artist touch, if I may, or is there some technical help or tip and trick situation that you can share?
Yes, I'm going to go back to when I see the patient in the clinic, the first thing I do, I just do the Seattle angle, the Ted Wagner angle. And that's usually the minimal thing you have to achieve, okay? Because you don't have, and then obviously I'll calculate the pelvic incidence in the OR before starting the case. I calculate the pelvic incidence, so to try to match roughly the lordosis to my pelvic incidence. And then when I've done the surgery, I just bring the CR fluoroscopy and I have, a goniometers where I just measure on the CR fluoroscopy how much lordosis I've given to the patients. So that's basically the 3 basic tools I use. The Seattle angle first, then the pelvic incidence afterwards when I conference the case before I scrub. And then once I've done all of my technique, my osteotomy is the protractor.
So you have a protractor, the Arlet protractor. We have to copyright that.
It's a long one. It's a long one. You can find it at Home Depot or some other place.
I look forward to seeing it in person. When I visit you in August, I look forward to seeing it in person. I'll take pictures and commemorate it.
Okay.
So your lecture pointed out a great thing. This is a good segue to the lab where Dr. Kent is going to take the role of Dr. Pauly. And that is the